You know, the world of clinical diagnosis, it can feel like this huge, intimidating, just impossible place to navigate. But what if I told you there's a map? A way to find some real clarity in all that complexity? Well, today, we're going to learn how to read it.
I mean, it's a challenge every single student, every clinician faces, right? You feel like you have to memorize this mountain of information. But here's the secret. It's not about memorization. It's about understanding that for every major territory on this diagnostic map, there's a single kind of beautiful organizing principle that makes the whole thing just click.
So here it is. This is our master map. We're starting way up high, at that 10,000-foot view. And from here, we're going to dive down into 6 key territories. And in each one, we are going to find that one simple rule, that one key that unlocks everything inside it. So forget memorizing roads. Today, we're learning how to read the whole darn map.
Okay, first stop. Imagine we're zooming in from that master map, descending down into this one specific region, eating and feeding disorders. As we get closer, all the fuzzy lines start to sharpen, and the big question we have to ask ourselves is, what's the one thing that splits this entire territory right down the middle?
It all comes down to one single, fundamental question: body image. Is what's happening driven by a distorted perception of body weight and shape? Yes or no? That's it. The answer to that one question tells you exactly which side of the map you're on, instantly.
And this right here shows that principle in action so perfectly. On one side, you've got AFID. That's avoidant/restrictive food intake disorder. Now with AFID, someone's avoiding food, for sure, but it has nothing to do with wanting to be thin. It might be about sensory stuff, like the texture of the food, or maybe a real fear of choking. But then, on the other side, you have anorexia nervosa. And here, the food restriction is all about that intense fear of gaining weight, that distorted body image. So you see, the dividing line is crystal clear. Just ask about body image.
All right, let's pull back. Imagine us rising up back to that high-level view of the master map. We're going to glide across to our next destination, the territory of schizophrenia spectrum disorders. Now, I know, from a distance this place looks incredibly complex, but believe me, the organizing principle here is so simple.
It's all about duration. Yep, just time. For a whole bunch of the core disorders in this area, the main difference isn't what the symptoms are, it's just how long have they been going on. It's literally all about the clock and the calendar.
And this table just lays it out perfectly. Just look, if the psychotic symptoms have been around for less than a month, boom, that's brief psychotic disorder. If those exact same symptoms hang around for 1 to 6 months, it's called schizophreniform disorder. And if they go on for more than 6 months, then the diagnosis shifts to schizophrenia. See? It's the same core issue, just stretched out along a timeline. It's a continuum that's totally defined by the clock. Okay, back up we go to the master map. This time, we're going to swoop down and look at 2 territories that are right next to each other, super closely related: anxiety and OCD. And the key here, it's not time, it's not body image, it's all about the specific target of the person's fear. Yep. For anxiety disorders, the key is the focus of the fear. To find your way around this part of the map, you just have to ask one simple question. What specifically is this person afraid of? The answer to that question, the nature of that threat, is what defines the diagnosis. And look, you can see it so clearly here. Is the fear about a thing, like spiders or flying? That's a specific phobia. Is the fear about being judged by other people? That's social anxiety. What if the main fear is, well, the fear of having another panic attack? That's panic disorder. And if the worry isn't tied to any one thing, it just kind of floats across everything, that's your generalized anxiety disorder, or GAD. The what literally tells you the which. Okay, now let's look right next door on the map. We've got OCD, anxiety's very close cousin. Think of this as our anchor point for this whole little region. It's defined by that classic 1-2 punch. You have these unwanted, intrusive thoughts. Those are the obsessions. And then you have the repetitive, ritualistic behaviors you do to try and neutralize the anxiety. Those are the compulsions. This obsession-compulsion architecture, it's absolutely key.
Because, and this is the really cool part, check out this table. The other related disorders, they use the exact same structure. It's just a different focus. So for body dysmorphic disorder, the obsession is a perceived flaw in appearance. For hoarding, it's about possessions. For trichotillomania and excoriation, it's this repetitive behavior, pulling hair or picking skin in response to this intense urge. It's like they all have the same engine,
They're just different models of car. Okay, let's pull back to the main map again. We're flying over to the land of mood disorders now. And this part of the map is all about topography, you know? It's got these really dramatic emotional peaks and some incredibly deep valleys. To make sense of it all, we first have to understand the building blocks that make up the terrain. So here's the thing you have to get. You don't really diagnose mood disorders directly. It's more like you're building with Lego blocks. You have three main types of blocks. First, the manic episode. That's a period of really high energy and elevated mood that causes some major problems. Then you have its smaller cousin, the hypomanic episode. Shorter, less severe. And finally, you have the major depressive episode. That period of low mood and low energy. The diagnosis comes from figuring out which of these building blocks a person has experienced over their lifetime. And this right here, this is probably the most critical dividing line in this entire territory. Bipolar 1 versus bipolar 2. So what's the difference? It's actually super simple. You just ask one question. Has this person ever, in their entire life, had one full manic episode? If the answer is yes, even just one time, the diagnosis is bipolar 1. End of story. If they've only had the less severe hypomanic episodes, along with depressive episodes, then it's bipolar 2. That one single building block, it changes absolutely everything.
All right, let's head to our final destination on the map for today, the territory of trauma and stressor-related disorders. And just like the name says, everything in this region is organized by one thing, its direct link to a specific stressful life event.
Now for the really big deal disorders here, there's a kind of gatekeeper. There's a gate you have to pass through first, and it's called a criterion A trauma. And listen, this is not just any old stressor. We're talking about a very specific, high-threshold kind of event, like being exposed to actual or threatened death, a serious injury, or sexual violence. You absolutely have to have that key to even open the door to a diagnosis like PTSD or acute stress disorder.
And what happens once you're through that gate? Well, what do you know? The map is organized by time again. If all those classic trauma symptoms, the flashbacks, the avoidance, if they show up but then they go away within 1 month of the event, that's acute stress disorder. But if those exact same symptoms stick around for longer than a month, you've just crossed the border into PTSD territory. The timeline is your guide, once again.
And so, let's pull back out one last time. Let's look at that whole master map again. It looks different now, doesn't it? It's not some confusing, overwhelming mess anymore. Because now we know the secrets. We know that eating disorders all pivot on body image. The schizophrenia spectrum, that's all about duration. Anxiety and OCD, it's the focus of the fear. Mood disorders are all about those episode building blocks. And trauma disorders, it's the type of stressor and, of course, the timeline. The point is, you know how to read the map now.
Look, this isn't about just ending here. This is about empowerment. It's about transforming a giant list you have to memorize into a landscape that you can actually navigate. So the real question I have for you is, now that you're armed with these key principles, now that you can read the map, which territory do you want to explore next? What path are you going to take?